Welcome back to the deep dive. Today we're charting a course through a really critical area of pharmacology. Treating anemia, our mission. Take chapter 55 on anemia drugs from Lilley's and, well, boil it down. Get to those essential high-risk nuggets you absolutely need to know. Because honestly, treating anemia, it feels a bit like walking a tightrope, doesn't it? The danger isn't just doing too little, but sometimes it's doing too much.
That's the perfect way to put it. The whole chapter really hinges on treating very specific deficiencies. So just to set the stage, quickly remember erythropoiesis. Red blood cell production is driven by erythropoietin, that a hormone that the kidneys kick out when oxygen's low. And these red blood cells, or erythrocytes, they're basically just bags of hemoglobin, HGB. And hemoglobin needs protein, sure, but critically it needs iron. So if that signal from the kidneys is weak, or the raw materials like iron are missing, well, that's anemia.
Okay, so step one is figuring out what is wrong with the production line, classifying the defect, because that tells you exactly where to go with treatment, right?
Yeah.
The chapter splits them into broadly maturation defects or excessive destruction.
Right. We can simplify those maturation defects if we think about where in the cell the problem is. The textbook has that nice schematic visual. If the issue is in the cytoplasm, you're looking at reduced or maybe abnormal hemoglobin synthesis. Usually this points straight to iron deficiency. And on a blood smear, those cells look hypochromic, kind of pale red and microcytic, so smaller than they should be.
And clinically, what's the most common reason for that iron deficiency? Is it diet?
Sometimes, but more often it's chronic blood loss. Think heavy periods or, and this is a big one, chronic GI bleeding, often from patients taking NSAIDs regularly, damaging that stomach lining.
Okay, makes sense. Then you've got the other big category, nuclear maturation defects.
Yeah, this is a different kind of production snag. It's about problems with making DNA and proteins correctly. For these cells to mature properly, they need vitamin B12 and folic acid. If they don't get enough, the cells end up chromic, so normal color, but this is key, macrocytic. They're bigger than normal. This covers both folic acid deficiency anemia and pernicious anemia. That's the B12 deficiency, specifically caused by the body not being able to absorb B12, usually because it lacks something called intrinsic factor. We lump both of these types together sometimes and call them megaloblastic anemia.
Gotcha. And before we jump into the drugs for those deficiencies, maybe just a quick word on the destruction side, hemolytic anemias.
Right, good point. These are where red blood cells are being destroyed too quickly. You often see weirdly shaped cells called spherocytes. Causes can be intrinsic, like sickle cell disease, that's genetic. Or they can be extrinsic, maybe drug reactions, infections like septic shock, or even physical damage. Think about mechanical forces from things like intra-aortic balloon pumps smashing the cells. Treatment there is usually quite different, often about managing the underlying cause, not so much giving supplements.
Okay, so classification points us to the deficit. Now let's talk about the drugs we use to sort of boost production. The erythropoiesis-stimulating agents, ESAs, epoetin alfa, darbepoetin alpha.
Exactly. These are basically synthetic erythropoietin. They give that strong hormonal signal straight to the bone marrow, make more red cells. Their uses are pretty specific, usually for anemia linked to end-stage kidney disease, certain types of chemotherapy, or sometimes with the drug zidovudine.
But here's the catch with ESAs, isn't it? They aren't really standalone drugs. You send the signal to make more cells, but you've got to make sure the factory has the parts.
Precisely. ESAs are, well, pretty much useless if the patient doesn't have enough iron stored up.
Yeah.
So the textbook really hammers this home. Most patients getting ESAs also need to be taking oral iron at the same time. Otherwise, the new red blood cells won't have enough EVA to actually carry oxygen effectively.
Okay, and this is where we get back to that tightrope analogy, the critical safety aspect. Like you said, the danger isn't just failing, it's being too successful.
This is absolutely the most important takeaway for ESAs. We're aiming for a really narrow window. Hemoglobin targets need to stay between 100 and 120 grams per liter. Why so specific? Because the studies were clear. When HGB levels went above 130 grams per liter, patients had serious problems. We're talking heart attack, stroke, and even death.
Wow. Okay, that's significant. You're giving a drug to fix a problem, and pushing it just a bit too far could have fatal consequences. How do clinicians manage that fear of hitting 130?
It means really careful, meticulous monitoring, following the protocols to the letter. And ESAs are also a definite no-go if the patient has uncontrolled hypertension. Makes sense, right? As the hematocrit goes up, blood gets thicker, pressure rises. Oh, and a quick practical tip. Don't shake the vial. It can actually break down the drug, the glycoprotein, and make it completely inactive. Waste of an expensive medication.
Okay, so ESAs give the signal, but you need the raw materials. Let's shift focus then to iron. You said it's the most common nutritional deficit causing anemia globally.
Yeah, it's incredibly common, especially in women and children. Iron's essential, obviously, for hemoglobin, but also for myoglobin in muscle. When we give it orally, it's usually as ferrous salts, things like ferrous fumarate, ferrous sulfate, ferrous gluconate. There are also injectable forms like iron sucrose for more severe cases or absorption issues.
Now, this seems like a huge potential pitfall. The amount of actual iron, the elemental iron, varies a lot between those different salts, doesn't it?
Oh, absolutely. It's a massive dosing risk if you're not paying attention. You cannot just swap the melanine for melanine. Like 300 milligrams of ferrous fumarate gives you about 100 milligrams of elemental iron. But take 324 milligrams of ferrous sulfate, which sounds like more, right? It only provides 65 milligrams of elemental iron.
Big difference.
Huge. They are not interchangeable. You have to calculate based on the elemental iron needed.
So, clinically, what should you tell a patient starting oral iron? What should they expect?
Well, first off, GI side effects are really common. Nausea, maybe some cramping, constipation, or diarrhea, it varies. And definitely warn them their stools will turn black or very dark. You need to stress that this is expected and harmless, otherwise they'll worry. Then there's absorption. Ascorbic acid, like in orange juice, boosts it. But things like antacids, milk, even some cereals with phytates, they block it.
So, if someone needs an antacid for the stomach upset the iron causes, they need to space it out.
Exactly. Take the iron, then wait at least an hour or two before the antacid or milk. Don't take them together. And we have to mention the critical safety alert here. Iron overdose. It's actually one of the most common causes of poisoning deaths in young children in Canada. Treatment is serious, involves supportive care, maybe GI decontamination, and in severe cases, chelation therapy with a drug called diferoxamine mesylate.
Right, very important warning. Okay, let's cover the last piece of that maturation puzzle. Folic acid and vitamin B12. Folic acid is vitamin B9, right? Needed for DNA, RNA, and making red cells.
That's it, water-soluble B-complex vitamin. Its big uses are treating folic acid deficiency anemia, obviously, but also, crucially, preventing neural tube anomalies like spina bifida in newborns. The guidance is really clear. Start taking it at least 1 month before pregnancy and continue through the early stages.
Okay, but this brings us to what sounds like the most dangerous potential mix-up in the whole chapter, the B12 trap. You said earlier both folic acid and B12 deficiency cause that same megaloblastic anemia picture.
Yes, and this demands extreme caution. You should never just give folic acid to treat anemia until you have definitively ruled out a vitamin B12 deficiency. Why? Because the folic acid can actually fix the blood results. The HGB might come up, the cells might look better, but it does absolutely nothing for the neurological damage caused by the B12 deficiency. So you end up masking a severe, often irreversible neurological problem while thinking you're treating the anemia.
Wow, okay, that's terrifying, actually. Fixing the blood count while neurological damage progresses unseen.
It's the absolute cardinal rule here. So if it is pernicious anemia, the B12 deficiency kind, then the specific treatment is cyanocobalamin, which is vitamin B12.
Okay. We've covered the hormones, the iron, the B vitamins. Let's synthesize this. Bringing all these whisks together, that 130 GL ceiling for ESAs, the B12 trap, the iron dosing. What are the absolute non-negotiables for safe nursing practice when dealing with these drugs?
All right, number one is assessment. Always get baseline HGB-HCT. Check iron stores before starting ESAs. Monitor vital signs closely, especially blood pressure with ESAs, because remember, it can rise as the hematocrit improves, and uncontrolled hypertension is a contraindication.
And what about actually giving the iron? Specifics for oral versus parenteral.
Okay, for oral liquid iron, tell the patient, sip it through a plastic straw. Always. It permanently stains tooth enamel otherwise. And after taking any oral iron, stay upright for about 30 minutes. It helps minimize irritation to the esophagus. For injectable iron, if you're giving IV iron like iron sucrose, watch carefully for hypotension. It can happen. And large doses need slow infusion, sometimes over 2.5 to 3.5 hours. If you ever have to give IM iron, which is less common now, you must use the Z-Track method. No exceptions. Prevents staining and tissue irritation.
And given the risk of allergic reactions, especially with IV iron.
Absolutely. Always have resuscitative equipment, including epinephrine, ready and immediately available. Especially if the patient has previous reactions or is considered high risk. Better safe than sorry.
Okay, that feels like a good wrap-up of the core safety points. So, recapping this deep dive, we've looked at the three main pillars for treating these anemias, ESAs, iron, and folic acid B12. And we've hit the critical requirements for each, needing iron for ESAs to work, the crucial difference in elemental iron content between salts, and that incredibly important warning about never using folic acid if B12 deficiency hasn't been ruled out.
Yeah, and maybe tying back to those ESA risks, the heart attack, stroke, death linked to going over that 130 GL-HTB limit.
Yeah.
It really makes you think, doesn't it? Considering how narrow that therapeutic window is, maybe the focus needs to shift. Not just treat the low number, but really master the complex risk management involved, recognizing that harm can come from both undershooting and overshooting the target, especially in high-risk patients. How do we best manage that balance?
That's a really powerful thought to leave our listeners with. How do you manage that fine line in practice? Thank you so much for walking us through that. Hopefully this deep dive into anemia pharmacology has given you that foundational knowledge you need quickly and clearly.
My pleasure. Thanks for having me.
Until next time on The Deep Dive, stay curious and keep learning.